Now, so we can conclusively say that IV TPA is the way to go about, especially within the first 3 hours, especially when CT doesn't show changes, especially when the age is young. So why are we talking about intra-arterial thrombolysis? Now we know that it's not easy to get a patient within the first 3 hours, so we are looking at ways to break that 3-hour barrier, and that's how intra-arterial thrombolysis has come into the picture. Now when we talk about intra-arterial thrombolysis, we have to again subclassify it as anterior circulation strokes and posterior circulation strokes. Now that is more because of the literature that's available in these two territories. Now have a look over here. None of these studies are actually got level 1 evidence, but we have got several studies that are listed out here, and we find, that the average time, it says the recanalization rates which have varied from 75% to 45% to 94%, and the ICH rates has been varying from 20, 18, 17, and so we have got this whole list out here, but none of these were basically a double-blind trial, and that's why we still call it as level 5 evidence. But this was the study that changed everything. This is the PROACT2 study, where they used, it was a multi-center trial. It was an open label controlled trial with a blinded follow-up in 54 US and Canadian centers, and intra-arterial pro-urokinase was given at 9 milligrams over 2 hours plus heparin versus heparin alone, and say about nearly the same point in time or a little more, and the primary outcome was checked at 3 months, and we said that which is the percentage of patients who had practically no disability or minimal disability at 90 days, which is the modified Ratskin score of 2 or less. So that was the basic guideline. Patient comes with stroke, and what is the outcome at 3 months, and then this was tabulated and it was studied. So have a look at this. Total screen patients 12,323. Finally, if you see, the clinical eligible patients were 2,095. On this, CT exclusion was 1,048, other exclusion 796, so we have got 474 patients. Angiographic exclusions were done in 365 because there was an incomplete MCO occlusion. We know that this patient even otherwise recover, and we found that it was not an MCO occlusion. Here they were more interested on M1 segment occlusion, and so they were left at 180 patients from the 12,300 that came, and a patient got pro-urokinase in 121 and a control was 59, and like we said, this was finally evaluated after 3 months after stroke. Here again you find 40% of the patients, the outcome was better compared to 25% with control. So there is evidence to show us that intra-arterial thrombolysis definitely makes a difference. Have a look at this chart. At 90 days, we have 18% of the patient who did well compared to 12% with the control group. If you use the Barthel index, it is 41% and 32%. Mortality is 25 versus 27, hardly any difference in the mortality except for a very small one. On the other hand, 66% of the patients should recanalize in intra-arterial. Just show every patient who recanalized doesn't do well, because after 3 years there's so much tissue death that outcomes still weren't as good as one expected. But there is a statistically significant improvement in the clinical status of patients on intra-arterial therapy. Now have a look at hemorrhagic conversion. Symptomatic in 10% against 2%, and a total of 35% against 13%, and at 10 days again symptomatic 10 to 4%, total 68%. So we have quite a few patients that actually had hemorrhage. Now we must understand, when we are talking about asymptomatic and a total, we are talking of very, very small bleeds which can be picked up on MR and may not be seen on CT, and many of them were not symptomatic. Look at the next slide. It just tells us that finally we know for certain that compared to placebo, intra-arterial pro-urokinase improved the outcomes in patients who had an angiographically proven M1 or M2 occlusion when treatment was started within 6 hours of the stroke, and there is level 1 evidence for that, so it's science. 15% absolute benefit. There is an increased risk of intracranial hemorrhage, but no increase in mortality. So we shouldn't be so obsessed by this intracranial hemorrhage, knowing that the final outcome is good. Just let me show you a few cases of intracranial thrombolysis. This is a 55-year-old male, came to us, 3 hours duration with hemiplegia. The power is 0, he's disoriented, the CT is. We do an angiogram, you find this total occlusion, the internal carotid artery on the left side. What you see filling is a part of the posterior cerebral through the posterior communicating. We take the catheter inside, shows a T-shaped filling defect as we angio through the microcatheter, and then we have recanalized the anterior cerebral, the microcatheter is on the left side, on the middle cerebral artery, and this is the end result. So obviously we would expect the patient to do well, and the patient did well. 46-year-old was admitted to the hospital for a thrombosed cardiac valve, and the patient was thrombolyzed, developed a deficit in the hospital. The CT scan was normal. The angiogram, if you just look closely, looks close to normal, but you realize on the lateral that there's a whole area of the MCA that's not filling. This shows a branch. It is the parietal branch which is occluded. We take a microcatheter. In a few minutes we have the vessel recanalized and the patient makes full recovery. You can see the difference now as all the parietal branches fill through the MCA, and the patient obviously did well. So this is how the lateral view shows before, and on the other side you can see after recanalization. But sometimes everything may not go well like the pictures we show. This is a 75-year-old male who came to the hospital, and the patient is having a grade 0 power. It's 3 hours and the procedure was done. Patient showed some signs of recovery, was started on tridofluban, and then he again showed signs of neurological deterioration. We started thrombolysis, no benefit at the end of 2 hours. We do a CT scan. You can see though recanalized, forward filling is very, very poor. CT scan shows a reasonably large hematoma in the basal ganglionic region. It progressed and the patient died. So that is one issue we have to know, and I think in this case that tridofluban probably aggravated the whole thing. 40-year-old male and an acute thrombosis in the brachial artery 3 years ago, was thrombolyzed. Patient continued the warfarin he was on, came back again to us with a stroke. We did the angiogram. You can find the MCA is occluded, the top of the ICA is occluded, and after 2 hours we find we have not progressed much, except that we could fill up the perforators a little more. Maybe in this case today we had done an angioplasty, I do not know. The thing was, there's cases of contrast, a small infarct, and the patient significantly improved and near total recovery at 3 months with mild dysarthria. So even I think if you can get the perforators recanalized, we may be able to improve the final outcome. Intra-arterial thrombolysis, efficiency with time of delivery. This just shows what we understood from this lecture also, that the faster you give the drug, better will be the result. So here at 3.3, 4.2, 5.3 and greater than 6 hours. So the ideal time is between 3 to 4 hours, and as you go beyond it, the efficiency starts dropping because tissue death becomes more and more significant.